Big picture is to be able to accurately analyze and mitigate foreseeable risk. That is why we want to do it. So we don't want to indulge in an academic brainstorm activity. Our purpose is to find, identify hazardous situations and be able to analyze the risk associated with those hazardous situations. Well, hello everyone and welcome. My name is Naveen Agarwal and I'm really passionate about risk management of medical devices. And for those of you who are joining for the first time, the purpose of these discussions is to pick a topic or a specific question that may be presented by one of the attendees in past sessions and focus on that, dig a little bit deeper and share some knowledge. So I welcome all of you. We truly have a global audience. Last time I checked the list of registrations, we have people from Germany, from Sweden, from Uruguay, UK, Bulgaria, France, Italy, Spain, Poland, Czech Republic, Ireland, India, and of course the United States. So we truly have a global audience and I really appreciate you taking the time and connecting with me today. Good morning, good afternoon, and good evening to all of you, wherever you are joining from. Let me tell you just a few things about these discussions, those of you who are joining for the first time. As I mentioned before, these are only for the purpose of educational information sharing. We are not here to talk about compliance or non-compliance. And most of all, nothing we discuss is supposed to be regulatory advice. It's purely for informational purposes only. Keep in mind that this is an open forum. And we are also recording this session so we can share this conversation with people later on who cannot join. With that said, there's a Q&A box that you can use to post your question or comments at any time during our conversation. And colleagues, today actually I'm going to focus on a topic that was suggested to me by one of my colleagues on LinkedIn, Christy Johnson. I'm not sure if you have joined or not, but I thank you for suggesting this topic because this presents a lot of confusion in risk analysis. Foreseeable sequence of events, hazardous situations. We are supposed to do all that, but it creates a lot of confusion. So I decided to focus on this topic and share a few thoughts with you, few tips based on my experience, but mostly invite questions and comments from all of you. So I want to start with just laying out a very simple, in my opinion, oversimplified, a traditional way of looking at things. And I'll explain to you how it might present a few problems for us. So we all know that generally there's an initial trigger event that leads to a sequence of events that leads to a hazardous situation where a patient or a user is exposed to one or more hazards. This is our conventional view. And we think of it in a linear way, starting from left to right. What we do not realize is that when a hazardous situation occurs, either through a surgical procedure or even after the patient has gone out of the surgical procedure or are using a device that doesn't require a surgical procedure, it can happen anytime, right? And when it happens, there is usually an intervention. And that intervention can lead to another sequence of events. Maybe they relate to the device, maybe they don't relate to the device. But this introduces a level of complexity because some harms could occur even after the procedure is complete. So the question is, how far should we do this analysis? Where do we stop? And what is the purpose of this analysis? So we're going to talk about all that, but make sure you share your questions or comments as you listen to this conversation. So I want to start with you with a simple case of a COVID test, rapid antigen test. I'm sure many of us took that test in the last couple of years. This is a very, very simple example, and you can see how a simple situation like this can become complex. So let's take a scenario where the patient has symptoms, but the test come out as negative. And over time, the patient's condition gets worse and the patient is rushed to the ER. This can happen. And one or more outcomes of different severities can occur. Throughout this chain of events, there might be many things happening. So if you are the manufacturer of a COVID diagnostic test, how far do you analyze your foreseeable sequence of events and hazardous situation. Let's take another scenario where maybe patient in a nursing home is given a routine test and the test is positive, and as a precautionary measure they are being taken to the hospital where they get infected. In a hospital environment, many things happen and they get infected and their condition gets worse. So it can build on itself. Now, I did a quick experiment and I went to FDA's website, TPLC website. Those of you who may not be familiar, FDA actually presents data about all the adverse events reporting. And I looked up this product called QKP, that stands for the antigen test. There was a long list of effects or patient effects that have been reported: anxiety, fever, viral infection, pain, allergic reaction, hypoxia, GI issues, sepsis, pneumonia, muscle weakness, and in some rare circumstances, even death. Now, these are reported adverse events. May or may not be related to the device. But the point here is that there are so many possible sequences and combinations of events starting from the single initial event. In this case, maybe a false negative or a false positive, and so many potential outcomes for the patient. How far should we go in our analysis? What is the best practice? And today in my conversation with you, I want to share with you my perspective on this, but keep your questions and comments coming. And I see Ed, you are sharing a reminder that the transition from ISO 14971 2007 to ISO 14971 2019 will end in December according to ISO rules. Allow US FDA ends transitions for product applications on December 25, 2022. That's correct. So they have given us a 3-year transition period, which will end in December of this year. So Ed, this is a great reminder that we should be mindful of this and pay attention to it, right? Some of you are already looking into it and maybe getting very confused. To the point of this slide, there are so many possible sequences and combinations starting from the single initial event, and so many possible outcomes that we just saw for a simple case of a COVID antigen test. How far should we go? Very, very, very legitimate question. And we're going to dig deeper into this, and I want to share with you my perspective. And again, this is not the only way of doing things. So I welcome you to share your thoughts. So let's first review what is the requirement. Clause 5.4 of ISO 14971 2019, the manufacturer shall identify and document known and foreseeable hazards associated with the medical device based on intended use, reasonably foreseeable misuse, and the characteristics related to safety in both normal and fault conditions. So this first part of 5.4 is all about identification of hazards, and we have to document that. The second part is for each identified hazard, the manufacturer shall consider the reasonably foreseeable sequences or combinations of events that can result in a hazardous situation and shall identify and document the resulting hazardous situation. Let me repeat that once again, because I think there's a lot of confusion around it. For each identified hazard that we have done in the first part, the manufacturer shall consider the reasonably foreseeable sequences or combinations of events that can result in a hazardous situation and shall identify and document the resulting hazardous situations. Our purpose of doing this exercise is to be able to identify hazardous situations. That's our purpose. So let's keep that in mind. So what's the main point here? The main objective is to identify all potential hazardous situations where the patient or the user is exposed to one or more hazards. Why? Because that is what relates to the harm. This is an important aspect of risk analysis. That is identification and estimation and subsequent risk control. That's why we do this. So let's keep the big picture in mind. So I want to emphasize a few things for you. The standard requires consideration of reasonably foreseeable sequences or combination of events. Reasonably foreseeable, 2 keywords, and we have to consider them. Here, foreseeable does not mean we have to imagine things. Again, that's my view. We don't have to imagine things. We can use our prior knowledge and experience acquired in a clinical context. That is important. So we are not going to imagine things. We're not going to do hypothetical brainstorming, what if. We're going to work with our clinical experts and actually talk about what could be foreseeable and what could be reasonably foreseeable. We're not going to guess. and going to improve our foresight over time. Because guess what? In the beginning, we may not know much about it. We may have some vague idea. I'm going to go with what we have. But as we get more information from the post-market phase, we're going to improve our foresight. Big picture is to be able to accurately analyze and mitigate foreseeable risk. That is why we want to do it. So we don't want to indulge in an academic brainstorm activity. Our purpose is to find, identify hazardous situations and be able to analyze the risk associated with those hazardous situations. And analysis is identification and estimation. That's what we are trying to do. Ed, you are clarifying that it's a fault condition, not single fault condition. And you're also saying foreseeable events include those that have happened in the past with this or similar devices. Perfect. That's actually a good point, Ed, because our foresight is heavily affected or built by our prior experience. And by our experience, I mean our collective experience. And that is why I want to emphasize that this conversation should happen in a clinical context. Not necessarily a few of us engineers, and I'm an engineer, getting together in a room with a whiteboard and try to brainstorm. That is not the best way of doing it. We really need to talk to the clinical experts about the actual use of the device in a clinical setting to be able to understand what might happen, what could be expected to happen. But even then, that's not an exercise from a purely academic point of view. Our purpose here is to identify hazardous situations so we can analyze the risks associated with those hazardous situations. Okay, great. So let's continue. Thank you, Ed, for those reminders. So I have a very pragmatic view about this. Okay, I don't want to get into a lot of academic conversations. I have a very pragmatic view about it. So let's map this out in a simple way. So we are going to talk about a device-related initial event that may or may not be a failure of the device. And let's say it leads to a series of hazardous situations through sequences or combinations of events, whatever they may be. And we can say maybe this is HS1, which is hazardous situation 1. This is HS2, hazardous situation 2, and so on and so forth, n hazardous situations we have found. And each scenario is leading to n harms. HM11, HM12 to HM1n, and so on and so forth. We can do this initial map based on our best available information in a clinical context. I think we can do that. The challenge is what happens next? Subsequent sequences of events with or without intervention. How far to go? Now here, the situation is not that black and white. It depends. Again, our clinical experience matters. If we know what are the typical interventions that are taken in a certain scenario, I think we can build further. If not, we don't have to. But we should do at least the initial cut of the analysis to figure out what kind of hazardous situations can be expected. So this should be our roadmap. Now again, our end goal is to be able to analyze these risks, correct? So let's go right into the probability of occurrence of harm, because that's exactly what we have to do as part of our risk analysis. And I want to remind us that it has two components. Let's go back to our simplified model where an initial event leads to sequence of events in a hazardous situation and harm. The first part of this is P1, which is probability of occurrence of a hazardous situation. And the second part is once the hazardous situation has occurred, regardless of how it happened. Once it has occurred, what is the probability of that hazardous situation leading to harm? And I know a lot of people get confused by these two, but it's very simple actually. We first think about the occurrence of a hazardous situation, which from our map, we should be able to map it out. And then we think about once that hazardous situation has occurred, what is the probability of occurrence of harm? And then we multiply the two probabilities to get to the probability of occurrence of harm. Okay, so we went into this refresher, so what? So what is analysis of sequence of events, in my opinion, is useful only to the extent that it allows us to identify opportunities where we can break the chain of events with additional mitigations. By doing so, we can potentially lower the P1, the probability of occurrence of a hazardous situation. So that's a purpose. That's why we want to do it. to the best of our ability as realistically as possible, because if we are vague about it, we will assign probably an inaccurate estimation of probability and our assessment will not be very reliable. So to the extent that we can do it and do something about that chain of event to break the cycle, I think we can use this, right? Now, what if we cannot? If not, then it's purely an academic exercise and we are better served by assuming. There's an assumption. If we cannot do it well, with clarity, with a lot of confidence in our estimates, then we are better served by assuming that if a hazard is activated, and I use the terminology activated, then exposure is certain to occur. So we don't care how the exposure occurs. We will assume if the hazard is activated, the exposure occurs. Which means what? Which means that the combined probability of all potential sequences of events is 1. That's how we can estimate our P1. So we will not be incorrect about that. We will just be a little bit more conservative. And as our foresight improves, maybe we'll outline more sequence of events and do something about it. That's the whole purpose. Okay, so what about P2? Right? That's only one part of the story. I think we can get to P1. We can do sequence of events analysis to the best of our abilities, given our experience in the field with prior devices or similar procedures. We can lay that out and estimate P1 for all those scenarios. What about P2? So we talked about it, right? Each hazardous situation may be associated with one or more harms of one or more severity levels, and certainly it can get very complex. Here's a very simple model that I want to share with you. Let's lay out again in our map all these harms. And let's consider all possible scenarios. We have 1 to 5 levels of severities. We can say 1 to 5. Let's establish our P2s. So how do we establish P2s? Remember, P2 is once the hazardous situation has happened, what is the likelihood that it will lead to a harm, a certain harm? That is done again working with our clinical experts based on all data available, all experience available, and all estimates. A lot of it could be just an estimate, but you can develop what I call a P2 table. This is what a typical P2 table might look like. For HM11, S125, you might have a distribution, and this is only for the purpose of illustration. Notice that these are probability numbers and they should all add up to 1. Similarly, you can do another distribution for HM12, a specific harm. It might look something like that. 1N, it might look something like that. There's a very good reference that I want to recommend to you, Safety Risk Management of Medical Devices, 2nd edition by Bijan Elahi. In fact, I learned this from his book. And Bijan and I had a conversation only a couple of weeks ago about some best practices in risk management. If you missed that, a recording is available and you can watch our conversation and learn a few tips from him. His book actually teaches you how to establish these P2 values. They are not exact. They are not perfect. They can be improved over time and they can be adjusted over time as new data comes in. A lot of it is estimates, our best estimates from a clinical view. Okay, so we could set up our P1s, we could set up our P2s, and that will allow us to estimate our probability of harm. Let me look at some of the comments that have come here. Ed, you are recommending a fault tree analysis as a tool. Yes, a fault tree analysis can help you estimate the probability of occurrence of a top level event. And the top level event could be a hazard activation. In fact, in Bijan's book, you will also find those examples. You're also saying, Ed, that the quantitative values must have statistical validity before attempting to use these numerical values. I would say, Ed, as much as possible. As much as possible. So I have a more of a pragmatic view. Now, you should have some level of confidence in your estimate. If your confidence is low, it is better to go qualitative. Don't have to do P1, P2. Just estimate the direct probability of harm and refine your estimates over time. But if you have fair amount of confidence, let's say 70-80% confidence, it is better to use a numerical estimate because that will allow you to monitor it over time and take action. So I'm of the perspective here is that as much as possible, of course, you should have a very sound statistical approach. But having done a lot of statistics in my career, even then your level of certainty cannot be very high. So to me, it's more of a pragmatic view, and I want to emphasize it's a pragmatic view. But whatever you use, whatever approach you use, you should be able to explain it, justify it, have a rationale behind it. And most importantly, you should be able to articulate your level of confidence in that data. So Ed, I'm not disagreeing with you. Absolutely, by no means I'm disagreeing with you, but thank you for pointing this out as far as possible. And it's a judgment call. There's a question here. How would you achieve statistical validity without having the product available yet? True. And what does statistical validity mean in the first place? Let's talk about that for a minute, because it's a vague term. Okay, people have interpretation around. I'm really careful about terminology. So what I mean here is level of confidence. You can do prediction intervals. You can do confidence intervals. You can estimate a number and create a confidence interval around it using statistical information or even qualitative information. You can say, hey, in this particular chart, I'm going to estimate S equal to 1, P2 is 0.3. But you know, it could be anywhere from 0.2 to 0.4. I'm not sure. You could do that. So basically we have many options. The good thing, and Ed, you're pointing this out, the standard doesn't mandate that you must use quantitative approach. Wherever possible, use a quantitative approach, because that's a better way of estimating it and taking action, because you can monitor changes in it. If you're using a qualitative approach, perfectly fine. Just document your assumptions, document your justification, rationale. What led you to give a certain rating to the probability of harm, or even P1 or P2, right? Document your assumptions. At the end of the day, what I'm trying to communicate to you friends is risk management is a lot about making decisions and making choices. But the choices we make should be grounded in some justifiable assumptions and a good, clear approach that we can articulate to anybody and stand behind it. Pass the red face test, correct? So that is what we are talking about. And you make a call. Do you have enough confidence in the information you have gathered or the experts you have talked to that you can assign a very high level of confidence in your approach? If so, you know, I will go with anything better than 60-70% level of confidence from a quantitative point of view, because to me that is better than just a pure guess on a qualitative perspective, right? But 30-40% confidence is not good enough. In that case, we assume a qualitative approach and take a more conservative approach. We take that step, and over time we try to make it better. So I hope that makes sense to you guys. Very good discussion here. Ed, you are further clarifying that most often quantitative is not advisable to use until we have actual patient exposure to the device in design validation or later. Yes, again, it's a matter of confidence. If you have enough clinical judgment available early on, in my opinion, it can still work. But it should be clinical judgment, not a guess, not a hypothetical scenario, because many of the devices that we work with may have a lot of clinical information already available. So you're going to estimate based on the best available information. And if not, you're going to make a qualitative judgment, take a more conservative approach, do the best you can, do benefit risk, even though some of the individual risks may not be acceptable, do benefit risk, overall benefit risk, go to the market, collect data, and improve your estimates. That's how it should go. So at the end of the day, you are making a judgment call. And I want to emphasize that because for some reason, in my experience, I've seen as practitioners of risk management, we are hesitant. We are hesitant to make a judgment call because we seem to think that we will make a wrong call. I don't believe in that. I don't believe in that at all. Because I have worked with exceptionally brilliant, capable people, and then they can make the right call. Don't tie their hands in asking them to justify their assumptions too much, but have a conversation with them. Do the best you can and make the best decision and improve over time. That will be my recommendation. Okay, so I'm gonna close with a couple of key points and best practices. And typically we stay around for about 30 minutes or so. So I'm gonna wrap this up. I want to just recap a few key points from my slides here, just for you as take-home messages. Use clinical experience to identify reasonably foreseeable sequence of events with the goal of identifying additional mitigations. It is not an academic exercise. The purpose is to be able to identify and estimate risks associated with hazardous situations. Keep the big picture in mind. The main objective is to identify potential hazardous situations where exposure to hazards leads to harms. It is not necessary to outline all possible ways a hazardous situation may occur in a theoretical sense. Use it to the extent that it helps you to estimate P1 and P2, because that's the end goal. Our goal should be to accurately estimate the probability of occurrence of harm. Analysis of sequence of events is useful to the extent that we can identify opportunities to break the chain of events by additional risk mitigations. This will help us to reduce the overall POH by possibly reducing P1. I think that's the goal. And when more than one harm or different severity could occur from a single hazardous situation, it may be useful to simply cover all possible scenarios by estimating P2s for each severity level using clinical experience. And I gave you that example in the table. So friends, at the end of the day, it's up to us how we use it, right? I want to emphasize the point that the standard is not requiring documentation of sequence of events. It's requiring consideration of sequence of events. Big difference. So don't get hung up on try to make a table with 10 different sequence of events for every hazardous situation. You don't have to. Do it only if it makes sense to you. Standard is requiring documentation of hazardous situations that you should clearly define. Now, hazardous situation may not be like an endpoint of something. If you are struggling for words, it's as simple as understanding and identifying what hazard the person is being exposed to, because that's what it's all about. It doesn't matter what the circumstance is. What matters is what hazard they have been exposed to. So very simple pragmatic view would be patient gets exposed to hazard X. That's our hazardous situation. But if we know more details about that, sure, we can outline them, right? That would make sense. But let's not lose the big picture. We do it only if we can do something about it, and it helps us improve our estimate. So I hope that makes sense to all of you. I would love to stay engaged and connected on LinkedIn. Please continue to share your thoughts, questions, comments, and let's continue the conversation. Now, one final thing I want to share with you are some free resources. Those of you, again, who are joining for the first time can take advantage of these free resources on my website. You can go to www.achieveexcel.com, free stuff. There's a knowledge sharing forum you can join for free, where you can engage with more than 200 colleagues. There's a hazard analysis template that you can download. And if you so desire, you can schedule a one-to-one conversation with me, no strings attached. My intent here is to connect and collaborate with you. So you can schedule a 30-minute conversation with me by going to this link and just look up my online calendar and book a meeting. With that, I want to thank all of you again for joining. Let's continue the conversation. Engage with me on LinkedIn. Share your thoughts at any time. Suggest topics and questions for future conversations, because as you see, this was all about a topic suggested to me by Christy. So you can suggest these topics for future conversations, and I'll be very happy to dig deeper into those. Wish you a good week ahead, and I look forward to staying connected.